All right, welcome. A very good afternoon. I'm told that this is it, so you are the blessed people in this room, and it will be a cozy last session of the day. And I will tell you, you will not be disappointed that you're here. So, very good that you're here. Building resilience to global health threats and leaving no one behind is really the topic of this session. And it's very important if we are to be ready for whatever global health threats there may come. We have to collaborate, we have to work very closely together, and we also need to see how the official development assistance is really coordinating with the national priorities. We have a stellar panel today, and I'm very happy for the three panelists who are here. The State Secretary of Norway, Björk Sandkar. We have, now I have to make sure I say it correctly, Her Excellency Princess Adejoke, Senior Special Assistant to the President of Nigeria. We also have Ms. Nurgul Janava, Director Forum of Women NGOs of Kyrgyzstan. So the panel is great, the audience is fantastic, and now I would like you all to watch a video of some 2 minutes just to set the tone for this session. You can go ahead with the video.
Communities in Costa Rica, like in many countries, were badly affected by the COVID-19 pandemic, including seeing a rise in gender-based violence and violence against children. A project in 2020 responding to the COVID-19 pandemic showed that community engagement in primary healthcare could be a path to better tackling wider health and social challenges. Funding supported the training of over 250 community leaders to share tools with communities and implement action plans. Underserved groups such as women and children, Indigenous and deaf communities were focused on to improve health equity. Awareness of gender-based violence and mental health was raised through media campaigns. This project built on learning and experiences from the COVID-19 pandemic to progress on the SDGs by engaging communities and empowering individuals to take charge of their own physical, mental and social needs. Future plans include adopting this community engagement model in other locations and for other health issues, potentially with other GAP agencies. This approach, alongside other work in the country by UNFPA, UNDP and others, has helped communities to help themselves, contributing to an equitable, gender-responsive, primary healthcare-led recovery from the COVID-19 pandemic.
That was a very nice glimpse of what is happening in Costa Rica and how they match health system strengthening with a response to the COVID pandemic. So now we are ready for the next part of our session. I have asked everyone to be slightly thought-provoking and also to be looking forward so that we don't leave this room at the end of the day with only gloom and doom. We do want to have hope, and especially for 23. So let me introduce you to my dear former colleague, Dr. Kumanan Rajanathan, Executive Director, Alliance for Health Policies and Systems Research, who has often said health spending is not a cost, it's an investment. And of course, we'd like to hear more from you. Please join us at the podium. Go ahead.
Can you hear me okay? That's fine. Great. Well, thank you, Karen, and it's a real pleasure to see you after a few years. UNICEF, such an important organization where I learned so much. Excellencies, distinguished guests, colleagues, ladies and gentlemen. As we've already heard today from Rebecca Greenspan and others, we live in a time of multiple interlinked crises. Of climate, of COVID-19, of conflict, and the cost of living. Our systems and governance are really being stretched to meet the aspirations of people for their lives, and really being challenged to deliver sufficient progress towards sustainable development goals. And we have an underlying pandemic of inequality. But as Karen says, we should not be all doom and gloom, because we know in our history, through major crises, we've often seen the greatest accelerations in progress. We've often leapfrogged and transformed our societies to meet today's challenges and also those of tomorrow. So in this challenging context, this session's theme is timely and important. Building resilience to global health threats is an area where the role of development cooperation can be crucial. And the health sector needs to take a leadership role, but it also knows to know when to follow, to genuinely acknowledge the role of other sectors. As someone who trained and worked as a clinical doctor, I know how hard we sometimes find it to follow. We have all now lived through the very clear demonstration of the impacts on health and equity of having insufficient resilience in our health and social systems. For example, a recent report by our colleagues at the Pan American Health Organization estimated that life expectancy in 2021 in the Americas had overall regressed to levels last seen in 2004. But while women in North America have seen life expectancy reduce by 1.2 years between 2019 and 2021, life expectancy for men in Latin America and the Caribbean has reduced by 3.1 years. That's almost a 2-year difference, and it shows the challenges of equity that we're facing. Indeed, COVID-19 has halted or even reversed progress towards many of the Sustainable Development Goals, reminding us that without health, there is no sustainable development. We used to worry, how could we convince other ministers that health is a whole of society endeavour? I think after the last 3 years, that is an easier argument to make, sadly. According to the World Bank, the COVID-19 pandemic has pushed about 120 million people into extreme poverty over the last year, reversing previous gains. The world is off track to reach the Sustainable Development Goals by 2030. Currently, we are progressing at a quarter of the rate required. So that does seem a bit doom and gloom. But we know that country leadership are essential, country ownership and leadership are essential to any progress, including towards the SDGs, as we were reminded today by President Kagame and many others. Countries also play an important role in incentivizing better development cooperation. But we have been talking about this for a long time through Paris and Accra and many other agreements and experiences. We still struggle sometimes to live up to these principles. SDG 3 Global Action Plan colleagues who are in this room have implemented a questionnaire to monitor country perspectives on development cooperation for health. In 2022, this tool was implemented in 52 countries and territories. Over 70% of country focal points reported that support they received from development partners is well aligned with national plans, as we've signed up to. However, only about 60% of respondents felt that development partners coordinate well with each other over the support they provide. Only 50% of country focal points felt that signatory agencies had developed joint technical assistance plans. However, the use of local monitoring systems was more widespread at over 65%. And I know myself, I recently finished 3 years in Cambodia, that sometimes the cooperation, the agreements we force in the crucibles of Geneva or New York or Washington, DC, become under pressure in the heat of country cooperation. And we do need to do better. We also know investing in health is a political choice and requires political will and leadership. The SDGs codify countries' commitments to achieve universal health coverage, which requires resilient and strong health systems. Today is, of course, UHC Day, which was first celebrated 10 years ago. So we've also been talking about this for a long time, and again have sometimes struggled to fulfill our commitments, as COVID-19 has shown. Because even though health spending is not a cost, but an investment, as of course we in the health sector would say, it's not so easy for political leaders to always make the choice for health. Many low and middle income countries are not able just to direct more resources to health, as at the moment they simply cannot afford to allocate more resources to health in the context of COVID-19 recovery, fiscal constraints, and increased debt burden. The projections we had in many countries for increased fiscal space have really been challenged by the experience of the last 3 years. World Bank estimates reveal most low-income countries will not be able to recover levels of government spending in health to pre-pandemic levels until 2026. And many countries are also likely to, in fact, decrease their government health spending over the next few years. So the picture has changed quite quickly. So that's why all of us here at this summit, why official development assistance plays a critical role in supporting national efforts to strengthen health systems to achieve universal health coverage and health security through the primary healthcare approach. Sometimes that can seem like a lot of buzzwords and jargon, but all of those concepts are important, and I know we all have the commitment in this room to make them happen. But we do need to be more relevant and more concrete. So ODA continues to play this crucial role in health spending. It's still an average share of 29% of health spending, with significant differences between low-income and middle-income countries. So while ODA continues to be an important driver of total health spending, and we know between 2000 and 2020 health spending from external sources increased dramatically, even outmatching government increases, we know we are challenged. As I was just speaking to the Excellency, the Minister from Norway before this, we all need to do things a bit differently. So how can we build on our efforts to do better? It's not just vertical versus horizontal. For ODA to effectively and sustainably contribute to universal health coverage, we need to first be clear what it is that we wish to sustain once ODA reduces and countries no longer receive ODA. To develop and implement policy that can successfully address these challenges, we need to navigate complex adaptive systems, understand the political economy that can obstruct or facilitate change, enable learning cycles to calibrate policy and drive effective implementation, and build institutions to lead. And my institution, the Alliance for Health Policy and Systems Research, works in a field that has aimed for the last 25 years to support just such activity. To give you an example, research between WHO Health Financing colleagues, UHC 2030 and the Alliance has helped to better understand what countries can do to enable sustaining coverage post the exit of development partners. And they've identified some key factors to sustain coverage. Strong political commitment and alignment, being deliberate on what development partners choose to fund with an eye to sustainability, domestic advocacy, and clear and committed timelines and inclusivity around transition planning. I'm sure we'll hear a lot more on that in the panel. So policy and systems research can also illuminate how best to eliminate new sources of financing for health, and such as health taxes. And I'd be remiss if I didn't recognise the support of the government Norway for the work we do in this area for policy analysis with our WHO colleagues. So in conclusion, as we strive to live up to the promises we've made in the past, address the challenges of now, and prevent the crises of tomorrow, a few questions for our panelists. How can we strengthen our partnerships for impact to develop on SDG 3? We need to rethink the role and model of external funding in low-income countries, which should prioritise increased support to investment to strengthen health systems. In countries where the ODA share of overall health expenditure is small, but can play an important role, further thinking is needed on what can be the crucial catalytic activities, what do we need in knowledge management and capacity building for the most effective use of resources for UHC and health security. Secondly, how can we enhance the voice of civil society and communities? And we have Madam Nurgul here to speak with us, so I very much look forward to saying, but government is important, but it cannot do it all. We know from COVID, we need whole of society approaches. And thirdly, how can we increase transparency and accountability? We need to address measurement gaps to track development assistance for health. That can sometimes seem very technical, but it's important. And our current mechanisms make it difficult sometimes to track how much support is given to health system strengthening and emergency preparedness. So we need greater transparency, but we need greater granularity. We in health systems, and I've worked in different parts, both vertical and horizontal, we need to better show the metrics of our impact to make the case. So this session provides an opportunity to reflect on these core questions for improving the effectiveness of development cooperation. And again, how timely on the UN Day for universal health coverage with the theme of Build the World We Want, a healthy future for all. Global health threats such as the COVID-19 pandemic reinforce that health is everyone's business, as pandemics do not stop at borders. Countries must come together with the global community to ensure coherent action through more effective development cooperation, which rests on alignment with national priorities and dialogue and decision-making processes that include all relevant country stakeholders. Thank you, and I'm very much looking forward to the answers, the solutions, and the discussion we're about to have. Thanks so much.
Thank you so much, Gunaman. So a lot of questions and a lot of provocations. So let's have the panelists on the podium with me. It's my pleasure to invite you, State Secretary, International Development Norway, Ms. Björk Sandkjær, Her Excellency Ms. Princess Adejoke, Senior Special Assistant to the President of Nigeria on SDGs. And then we also have Ms. Nurgul Janava, Director, Forum of Women's NGOs of Kyrgyzstan. So please take a seat. And I'm Karen Hulshoff. I'm the Deputy Executive Director of UNICEF. So what we will do in the next 30, 40 minutes, I'll have a question for each one of you. You all get 5 minutes. And then we look to the room if there is anyone who has a burning question or a solution, as Gunaman was asking for. And then I give at the end each one of the panelists another opportunity to share a takeaway that they take away from this session. So if I may call you Björk, that's okay. What's Norway's experience in using official development assistance both in bilateral and multilateral cooperation to support health system strengthening efforts in developing countries through primary health coverage as the most effective way to achieve sustainable results in terms of universal health coverage and health security? There you go.
Thank you, and thank you for bringing us together. Indeed, it's great to be here on UHC Day and to have this very important discussion, a very important discussion for Norway as well. Global health is an area where Norway has been involved for a very long time, starting decades ago with missionaries who traveled and built hospitals and provided healthcare. Partnership now looks very different. And I think that's interesting as we sit in this conference talking about development effectiveness, that we recognize that we have come. I think we are very serious when we talk about mutual accountability, and we talk about partnership, and we talk about the importance of country ownership, because these are lessons that we have really learnt along the way. And what we are discussing here is really the importance of getting to that point of resilience and how health system strengthening can help us with that. And as we heard from the great introduction as well, we have made progress over the last couple of decades. But unfortunately, a lot of that is now being reversed, and or at least we are not progressing as fast as we could have done, and we are certainly not on track to get to where we want to be in 2030 in terms of the Sustainable Development Goals. But rather than dwell on the challenges that we know very well and you described very well, I think it is important to look at the lessons we've learned, in particular of the last couple of years of responding to the COVID pandemic, and how we can use those lessons to move forward to build those strong health systems and the primary health care that we are looking for. One lesson, I think, was that we were not prepared when the pandemic hit, although we had received warnings for years. The World Health Organization published, the biggest risks in global health. Pandemics were right there. But until it really hit us, we didn't muster the kind of resources and energy and focus that was required to actually mount a response. But we did it, Norway was very involved together with South Africa and other countries in getting together Act A, which included COVAX. Now, the COVAX initiative was able to help provide vaccines at record time, but it also, of course, the pandemic also exposed inequities and challenges in the global systems that we have. And the evaluation of Act A has given us some very clear pointers as to where we need to work in the future. And one of those is that we need to be much more focused on local manufacturing and the ecosystems around manufacturing of the products that we need to respond. Now, obviously, products are only one part of the system. It won't solve anything if we have all the products available, but it's an important part and an area where Norway is very involved at this time. So Kumanan also mentioned the Global Action Plan and the research that's been done in the context of the Global Action Plan and the countries that are involved with that. And that work has provided us with some important guidance, but I'm not quite convinced that we are delivering. We have a global health architecture that in many ways was set up also in response to various crises over time, and were adequate and good responses at the time. The crisis of HIV and AIDS at the turn of the millennium gave that impetus to create the Global Fund. The crisis of reduced childhood vaccinations rallied us to create Gavi, the Gavi Alliance for Vaccines. After the Ebola crisis, it rallied us together to create CEPI, which is important now in vaccine research. And there are other initiatives as well that I think were important at the time. But where we are now, that we want to support systems and we want to bring countries much more. I mean, countries are involved. Civil society is involved in everything that I'm talking about. But I think we're becoming more and more aware of, if we are to really take seriously the issue of country ownership, we also need to bring a lot of this, whether it's the planning, the production of services and products, much more close to the country level. We have discussions about localization. I think that's very similar to what we call country ownership. We need to push. There's a question of power here as well, to push power down, push decision making down, which is something that's very important in the Norwegian response. And you asked about Norwegian experience. So we have some bilateral experience. Mainly, one of those is supporting a global public good, the DHIS2 system, that we are very proud of. It's a health information system that was started at the University of Oslo. It's open source, open access. Right now it's being used in 73 countries. Programmers are programming everywhere in the world. It's not something that we feel that we own, but it's something that we own together. And that when COVID hit in Norway, we actually started using it in Norway as well, because we found it to be the most convenient system to use to keep track of the pandemic in our own context. But mainly, Norwegian support for global health is in partnership, and it's very important for us to work in partnership with other countries, with the multilateral institutions. It's very important for us to work together with academia. We need the data and the knowledge, but we also need the civil society and the communities. Because one thing we know, if we are going to realize the right to health, we do need to have that strong participation of communities, in particular those communities who may have less access to the health system. And that doesn't come by itself. So there are so many levels that we need to be engaged at to achieve what we want to achieve. And I would like to just take it down to that the aim is to realize the right to health for everyone.
Thank you very much. Really thought-provoking. So maybe, I hope there is some question on the 71 countries and what that health system can also, that monitoring planning tool can help the countries with. Now, I would like to invite Her Excellency Princess Adejoke And maybe you can focus on what are the first-hand experiences, lessons learned and good practice of Nigeria in creating the right incentives to ensure that development cooperation in the health sector is being used to accelerate progress towards universal health coverage. So the floor is
Thank you
yours.
so much for this very important meeting and for us to look at how we can work together better for the benefit of our people, especially at this decade of action. And let me say that during the Millennium Development Goals that terminated in 2015, Africa country came into that to rejuvenate and bring about development, especially in health sector and education. And it has helped before the adoption of the global goals, the Sustainable Development Goals. And made us prepared better than before. And Nigeria and Africa as a whole came up with a very robust action plan on how, and framework on how to attack global pandemic. Especially in 2014, when Ebola came into Africa, Nigeria in particular. And I'm happen to be the deputy governor of Lagos. It happened in my state. My governor was not in town. He traveled out. I was in Lagos, and it happened right in Lagos. I took charge when Ebola came into Lagos. And of course, yes, we have the support of the national government, and we're able to condone that, isolate all concern. I gave instruction that no one should leave the hospital environment, especially those that treated the patient. Otherwise, it will have been a calamity. So aside from monitoring those that took the patients, we have also developed a we call something contact tracing. Those people that are in the plane with the patient, all of that, we took those information to be able to monitor those people that came with the patient. Of course, yes, we lost some people, few people died, but if not for the proactiveness, it would have been an issue before my governor came in. And it's a call to action for us to prepare. And from then, 2014, we anticipated that more can come. And so we are prepared. And the Sustainable Development Goals gave us a broader view of how the health care coverage should be done. And I remember that was when the health insurance took preeminence in Nigeria, both at the national and at the sub-national level. The national government took charge, encouraged the sub-national government to be able to work together, to be at the same page. And that's why the integration and domestication of SDG at national to the sub-national was one of the things that helped Nigeria government. My office took charge with UNDP and some UN system to integrate the SDG target and indicator into the sub-national government. And we're almost completing the entire state, the 36 states in Nigeria. Right now, we are doing 19 states. And before the end of the administration, we hope to complete that so that we can be on the same page and doing the same. Of course, one of the things that also helped us is the fact that Nigeria was the first member state in 2017 to have adopted the private sector participation for SDGs. Was the first in, I remember February 2017, when we inaugurated the private sector advisory group for SDGs, especially in education and health sector. The private sector working with the public sector will help us in terms of investment and support. The CSR and corporate social responsibility in their immediate environment, especially at the rural communities, riverine communities, targeting the older people, targeting vulnerable population, targeting the people with disability is very key to us so that we don't leave anyone behind. So we have the support of the private sector, and also, aside from that, working with us now, the non-state actor, the state actor working together, even before COVID came. Also, we have the lawmakers, legislative arm of government working with us to ensure that we have support of relevant legislation, working with the executive to work with that. We have the private, the civil society organization that monitors, working with us, the non-governmental organization working with us. We have this group launched for the sustainable development, women organization, youth organization, with people, the organization working with the people with HIV/AIDS, the people with disabilities, vulnerable people, and in the community development, in the rural development, we make sure that the health sectors are there, wherever they are, they have the access to healthcare system, so that when there's need, they get necessary support. And of course, the private sector investment on healthcare sector, building hospital. Between 2015 or 16 now to now, we have many international standard hospital built by the private sector, because there was enabling environment, the private sector participation, PPP has been strengthened, law has been strengthened, both at the state level and at the national level. So it's only when we work together, state actors and non-state actors, all of government and all of society working together, that we can get this. And one other thing that we have found very interesting is the buying of the beneficiaries, the people, because also we to ensure that inclusiveness, right of participation are into this. So we engage them regularly, town hall meetings, community development meetings, civil engagement on this, even before COVID came. And because we have done that for so long, when COVID came, the impression of the world was that Africa would be, all of us would die in Africa because of the poor healthcare system. But because we have engaged them, they know what to do, they know where to go, and what to do. So, and that's why we have less number of people that died during the COVID, because we were so afraid when COVID came. But because they knew what to do at the right time, and that was why we have manageable deaths, even below what we anticipated. So what we plan to do going forward is to continue the engagement, continue to work with the private sector. And one interesting thing that we have done, that we launched at the margin of the 77th General Assembly by Nigerian government, is to launch the Integrated National Financing Framework. That one comes up tomorrow. And Nigeria is the first from the Global South that have just done that. That gives us proactiveness to know that where are the gaps, what are the costing, what do we need, how do we source the funding to be able to meet up the funding to meet up to accelerate the sustainable development goal, achievement of sustainable, especially at this decade of action. We are not saying that everything will be done by 2030, but we are making progress on as we go. And I'm sure that where we are before that was not where we are now. We've made significant improvement and we'll continue to make improvement, working with other stakeholders, critical stakeholders. And the belief of our people in us give us some level of belief that it will be better. So I think that the evaluation report that we launched last year, early this year, the first quarter of this year, independent evaluation on SDG 4 and 3 and 4 also is another way where we see, evaluate what we have, where are the gaps, what do we need to do more. And we try to do that, we launched the report, and we are trying to analyze the report. We're still working on SDG 1, 2, and 8 now. Work has started also on that. So we want to be proactive to be able to help our people to work together, and we are very hopeful that we'll make a lot of progress. We have fantastic UN system working with us, and we are benchmarking ourselves on the baseline report, regular baseline report to assess where we are. And of course, the other thing that I can say that is very unique also to Nigeria is that we simplified the SDG target and indicators in different languages for our people to understand. You know, we have about 250 ethnic groups in Nigeria. We simplify it so that people can see. And of course, we have taken it to schools, primary and secondary school, in cartoon form to the primary school and at the high school to educate them, to catch them young, to understand how they can be of help to themselves and to the society. Thank you.
That's a message of hope. Thank you. And now I would like to give the opportunity to Ms. Nurgul Janava, Director Forum of Women's NGOs of Kyrgyzstan. And probably you get the most difficult question. What are the opportunities for civil society organizations within the health sector in Kyrgyzstan and maybe beyond to help to leave no one behind? So it's really now the focus on leaving no one behind. The floor is yours.
Thank you very much for an opportunity to share some thoughts and some experiences. First of all, I would like to say that Kyrgyzstan, sometimes I am criticizing Kyrgyzstan government, but in this case, I would like to say that Kyrgyzstan government is doing quite progressive work toward recognizing the importance of inclusive partnership. It has signed the Universal Health Coverage Global Compact, and within implementation and partnership for universal health coverage, there is a recently signed a joint statement which is actually calling for using a set of principles which are very similar to the development effectiveness principles. They, for example, talk about leave no one behind, ownership, move away from singular focus, national institutions. So Kyrgyzstan government is trying now to move towards effective inclusive partnership. Now, having said that, where is the role for civil society organizations? I think the political will is there to provide the space for civil society organizations to participate in decision-making, discussing even the formats of transferring from external funding to domestic funding to diverse areas of issues. But I would think that civil society, why government and why the sustainable development needs civil society deep engagement. First of all, civil society have deep expertise. It has evidence, data. It is advocating. And in the health sector, Kyrgyzstan civil society, for example, is demonstrating fantastic potential to strengthen the health system. For example, the Alliance for Reproductive Health in Kyrgyzstan was significantly, with the concrete steps, contributing to legal reforms, with providing specific, very needed services. It even sometimes was helping and drafting clinical protocols. The health sector, people know that it requires expertise. I want to say that civil society have expertise, commitment, knowledge, and they know whom to contact, how to raise the voices of those that are most disadvantaged. But there is a political will, but the practice at this moment still is far from being perfect. But before, one of the important things that in health sector and in other sectors in Kyrgyzstan, the civil society participation is not institutionalized. And it's a serious issue of concern because government and donor agencies practicing selecting civil societies whom they know or they prefer to invite. At the same time, there are so active civil society organizations that are not waiting invitation. They're just knocking the doors, entering, if the door is closed, entering through the window to get their input and to bring the voices. And you told about leaving no one behind. Are there people that are left behind in Kyrgyzstan? Especially in pandemic period, the dramatic figures that are talking about the weakness of the health system in Kyrgyzstan are demonstrated. Within half year of the pandemic, first half year of the pandemic, 16 pregnant women died. This is a disaster. Secondly, if we look at the maternal mortality rate in the open data statistic of Kyrgyzstan, mortality in some provincial districts, for example, Issyk provincial district, mortality during 2021 increased 2.5 times. This is demonstrated about the weaknesses of the health system. From 37 per 100,000 live births in 17 to 98.7 in 2021. Another mountainous area, very remote, very mountainous area, Narin rural province. Can you imagine? This figure increased from 16.6 in 2020 to 157 in 2021. This is official data. And that means that there are so many groups, communities, marginalized population who are actually not taken into consideration, whose needs are left, and they are left behind. That means the women's organizations, health area working civil society organizations are very much needed to not to collect this data, but to reflect in decision making and in transition to new area of sustainable development, from external funding to domestic funding, for example, to consider very seriously these gaps and to bring these voices. Also, I think some lessons learned from this experience in Kyrgyzstan. We need strengthening inclusive partnership and actively involve CSOs as development actors in their own right in the health sector. Reforming processes is needed extremely with and this is very important, with regular multi-stakeholder action dialogues. The civil society in this room and at this summit, we are calling that the monitoring will be followed by country dialogues. But country dialogues will be empty if sectoral are not bringing substantial input with civil society data, with civil society analysis, with civil society recommendations. Second, successful transition from external funding requires strong participation of civil societies in assessing and configuring governance, financing and service delivery. Civil society organizations' participation should be institutionalized. That's why probably some other countries have this experience, but as we know, the data shows that it's not only in Kyrgyzstan. Civil society participation is not institutionalized. What does it mean? They are not actually fixed slots and fixed places where you invite or you're obliged to bring civil society. We don't want to sit when you report, for example, when governments report or donors report. We want to sit in planning processes. We want to sit in monitoring process and capacity of organizations to monitor ODA, to monitor the transition from external funding to domestic funding should be increased so that to ensure everyone has access to health services without facing financial hardship. And the last one from the lessons, it would be of positive impact if all health partners, and in Kyrgyzstan it's UN, WHO, many partners, not only thematic area, but also donor sites, if all partnership, in partnership will make with visible efforts to retract restrictive and repressive laws that are disabling currently in Kyrgyzstan, civil society organizations, increasing reversal of the trend of shrinking civil space that hinder full operation of civil society in my country and not in my country, unfortunately, all over the world. And this is the voice from civil society from all over the world also. Enabling environment and partnership are extremely important, and their commitment should be monitored and guide how stakeholders should partner better. Thank you so much.
Thanks a lot. Really good. It's a bit of a sobering picture, I would say, but at the same time, it shows the essence of reaching everyone. We need to make sure that we listen to everyone also. Thanks a lot. I turn to the audience. I would like to invite anyone in the audience who would like to comment or who has a question or who has a deliberation to make. The floor is yours. We have a few minutes for that. May I invite you? I'm not sure if there is a microphone. Otherwise, I invite you to come to the podium and you can make your contribution. Yeah. Welcome.
Thank you very much. My name is Nasser Al-Qahtani. I'm the Executive Director of AgFund. AgFund is a partner with the United Nations, especially with UNICEF. During the 1890, we're doing a lot for providing women and children vaccine all over the world. So this is happening and repeating again. This is, I'm asking, if that's happening during the 1890s, during the 80s, working too closely with UNICEF, make the situation of the women and children, when the UNICEF come up with the Karabal 1994, improving the health of the women in Africa, that was recognized. Now with the pandemic, because we work as a microfinance, we have microfinance in Sierra Leone. When we have the pandemic, the first people we call our banks in Sierra Leone because they have experience dealing with Ebola. So African people are prepared before any other countries when it's come to, because they've been, happening something. My question is this: how can we be effective partnership happening with involving private sector? I'm talking loudly now because through financial inclusion, we have to include women and children in insurance, health insurance. And we do this when we give a loan. If there is any way, because as you know, it's cost and government got to be responsible, or if they cannot afford it, they could even have it with the reinsurance, which is a premium from outside the retail. My, question and proposing, we need more involvement for private sector involvement, especially in Africa, and have more, access to health education, health services. It could be with the neighbor countries, because building an institute or something is becoming very costly. It's not even for the government itself, if they want to do it for their own country in Africa. It's not an easy, because the cost is becoming too high. The only way, with effective partnership, that's government, private sector, and NGOs, because advocacy get to work together. So how can we, as a balance, government is here, NGOs and UNICEF as well, how can we work together with make ourselves prepared? Because this is expecting, with the climate change, something is happening. So how can we be effective and be prepared? Can we use science and technology? Now, there is a lot of tools and meaning how, with the primary health, it could be using technology. You should not go to the hospital. And we noticed this during COVID-19. Most of the patients, they don't go right away. They take, to call in doctor. So how can we effectively using science and technology to make the cost of health is affordable, no matter who paying it, donors or government or individual? How can we do this? And this is my proposing to the panelists. And thank you very much for giving the opportunities.
May I ask you to whom you are directing the question? All
of you, including UNICEF.
Okay, I was afraid so. I see another hand from the floor. Yeah, if you can, because then everyone can hear you.
Okay. Sorry for that.
No. Yeah, here.
Here I come again.
Welcome.
Thank you very much. I'm Isabella Toth. I work with CORDAID in the Netherlands, and we work in mainly in fragile and conflict-affected states, and one of our things is system strengthening also in these states. So thank you very much to all panelists for your interventions. Whilst I was listening, I was thinking there are so many different issues all together at the table. So I want to flesh it out a bit to understand what are we talking about, and if there is some kind of prioritization. And actually, my question comes already about what do you think that makes things work? What are because you said also to go out with some positive mojo. Because, yes, what we did the same. Ebola in Sierra Leone was our lesson. So when COVID came, we felt kind of prepared because we went back indeed. How did we do that? So we shouldn't be that surprised that it doesn't fall from the air. So what makes it work to not be surprised every time? We heard also earlier today in the beginning, somebody, pandemics will come, this and that. So it's not an excuse to not be prepared anymore. The second thing is something happened, and Thomas, sorry for that. I loved your firefighting metaphor, because how do we firefight and then we stop firefighting, or we don't stop firefighting, but at the same time invest in long term? Somebody else kind of countered that argument earlier today, saying like, what was, I think, the gentleman from DevEx, Raj Kumar, he said that use the firefighting lessons to accelerate the normal. Fair enough, we learned enough. COVID learned us as organization that without strong local structures and infrastructures, I'm talking grassroots, nobody's anywhere. Let me put it this way. The biggest challenge was the remote way of working. Then the other thing is, the third thing is, with universal health coverage is suddenly in it. That is for me very linked to human capital development, and health So human capital development, from the cradle to the grave, education, health, offer the person everything that it needs to live a decent life. So in that sense, how do you see to strike the balance between preparedness, firefighting, and working towards a decent health system with, don't want to use big words, because behind each of these words, there are actual people who are making use of, hopefully, timely access to quality services. Thank you.
Yeah, thanks a lot. So I think we leave one more question. That's our last one. Please go ahead.
Thank you very much. This is Santa from CPD Asia, CPD Feminist Group, and Beyond Beijing Committee, Nepal. Very impressed by the sharing and by the deliberation, but I have one unique question that is about whole society approach. I think this is becoming a very catchy and very, how should I say, re-emphasized concept and term. We all know that, especially when it comes to women and girls' health, their healths are more detrimental, not just because of primary health services, but because of the norms and values, social norms and values that are really discriminatory to them and even prevent them from getting access to those services already available. So my question here is how to use that whole society approach to really not only to provide services, access to services, but to really transform those norms and values which are really preventing them from having those access to health services, primary on sexual and reproductive health, because we are discriminated mainly because we being female and we have womb. And that's the reason how to really use that approach for transformation. That's my question to all. Thank you so much.
Thanks a lot. It's getting more exciting the closer we come to dinner, but I will leave it at this. So I will turn to everyone for another last word. I think it's a lot to sum up. So I just ask you to give an instant reaction. What is one takeaway for you, Secretary of State Björk?
Yes, thank you. I hope I can have two, because the first one is linked to the last, actually all of the comments, but that is, that the health is produced in society and repaired in the health service, right? So the norms and discrimination, all of this discriminatory norms, practices in society have to be, I agree, we have to deal with them, and that's what I meant when I said that we need to work on, have a human rights-based approach to access to healthcare. It means everybody needs to be able to access what services they need without discrimination. But we can't fix all of society with primary health care. So we just need to separate what we need to do where. But I agree, we do need to work on those discriminatory norms and practices in societies that exist everywhere. We have them in Norway as well. It's not like it's, we have them, we need to do something about them. We also, and then my second point is, I think we need to realize health services are part of the fabric of society and risk reproducing some of those norms. So we need to look inside as we work to strengthen primary health care, to see how we can ensure that we don't make the same mistakes when we set up our services. And one way to do that, because there was a comment about financing, is that we need to think very carefully about how we finance those services. We've tried user fees. User fees is not very conducive to access if we really want everyone to have access to healthcare services. But somehow primary healthcare has to be financed. So looking into pooled financing, pooled risk financing mechanisms will be important. But I think it's important that as we move into that direction, that we take care that we don't create financing systems or insurance schemes that exclude the poor. And there are risks of that happening. And so for Norway, it's very important that as we move forward to support the creation of primary healthcare services, that we make sure that we don't put up new barriers to access. So I'll stop there.
Thanks a lot. Your Excellency.
I think that the social development aspect of the sustainable development goals very key. And one of it is the healthcare services. Very important, and if that is not achieved, I'm afraid if other sustainable development goal can be achieved. Because sustainable development goals itself is about people, and it's about good health and well-being. So if you are not healthy, you cannot make a meaningful opportunity or prosperity. So the health education one is very germane, very important. Health education. Education is very key. And health education on radio jingles, community engagement, town hall meetings where if you feel very unwell, go to the hospital. Access to healthcare services is another thing. So if you are unwell, you go to there, you get treated, and you come back home. And the law that we made on healthcare, health insurance helps, because you don't have to have with cash, physical cash. Some of the issues that militate against our people is when you have to put money down. When you go to hospital, you have to pay. Some may be poor, they may not be able to pay. But with health insurance, that helps and has allow more people to get into that. Another one is about maternal mortality and infant mortality. Initially, during the MDG, I said we learned, the essence of that was in 2015, we were able to learn, take our failures and gains. Then, so we discovered that now we built more modern child hospitals, modern child hospital from gynecology to antenatal, delivery to postnatal, and immunization. So the level of the mortality between 0 and 5 has reduced significantly. And pregnancy cannot be a death sentence anymore, like before.
Thank you.
So, and if you have money, under health insurance, you pay. Under insurance, you are covered. Even if you don't have, that cannot kill you. You'll be taken care of. And that is the most important aspect of all what we are talking about. But I think that the private sector comes in here. How? Investment. One. Second is on corporate social responsibility. And the CSO, civil society also comes to monitor, to help. And that's a whole of society approach, come to join the whole of government activities. So it has to be two levels, all of society and all of government working together to be able to achieve that. And I want to also talk about young girls, because the young girl of today comes tomorrow. Personal hygiene, healthcare, health of the young girls is very important. And that's why we engage young girls on what to do. Of course, as we engage the pregnant women, we give them money every month. If you come to antenatal regularly, at the end of the month, you'll be given some transportation fee to encourage them to come. Because if they don't have money to attend the antenatal, there might be issue during complication during childbirth. So we give them as much as 5,000 naira every month to encourage them to come. So the same thing to the girls. They have to be in hospital. If you have anything, come to the hospital and be taken care of. I agree with my sister that said there are so much gaps in healthcare system for the young girls. But we continue to educate them because education is very key. Health education is very key on what to do at a particular time. Without health education, we might have a lot of issues.
Thank you.
So,
Let's also answer to Nur.
yeah.
Thanks a lot. Nurgul?
Thank you. I actually was thinking about other takeaways that I'm going to share with you. After lessons from private sector, from ISA, and after your listening to your wisdom, I think I have some other takeaways that I was preparing for myself. First, I think that the whole session, for me, demonstrated a very big need in order to strengthen health system, the whole cooperation be effective, which means we should be in partnership. But partnership is a very high political word, requiring very detailed plan of partnership with very detailed differentiated responsibilities. We don't have that. So that means that we are not using very targetedly power of money of the private sector, for example. We are not using probably power of civil society, of the data, of the evidence. But there should be a concrete mechanism of multi-stakeholder partnership in the health sector targeted at specific area with very detailed plan with differentiated responsibilities. But it is extremely important to have their institutionalized seats, so the trust between everyone who is working on health sector was built through the cooperation. It is built when you know our own challenges. For example, private sector. In Kyrgyzstan, there is a big tendency to privatization, which is a huge risk, because you can't privatize everything. Private sector for profit. We need something accessible, high quality, that is coming from government or from other resources. But that should be used so the partnership shapes the values, and differentiated responsibility, extremely important, with concrete indicators of success at all stages. Thank you.
Thanks a lot. So this is really a very rich panel, and I'm really amazed that the last session of the day we got so into this. Thank you also for the different questions we got, and you asked me, you challenged me also, so I will not summarize further, but I just like to say the most deprived first. Any society who is able to put the most deprived first in basic healthcare services will be a society that is also able to expand rapidly everywhere. Early investments in systems and preparedness, that's the foundation, I think, of strong health systems. And indeed, the trajectory, as you also mentioned, to new and innovative financing. If we marry all of that together, I think we are set for 23 and beyond. Thanks a lot, Kunaman, for being the keynote speaker. And I invite you all for dinner, and I see you all tomorrow, hopefully again, in good health. Thank you.